is a director, Department of Digital Health and Innovation, WHO, and we are very glad to have his video. And we also have a very distinguished keynote speaker, Professor Ahmadul Kabir, and he is a Additional Director General of Planning of DZHS. And with that, we have two parties, as I said, from international and national. So we have a government stakeholders who actually realizing all the DPI or PPI, also service delivery for our 170 million peoples. And I am very happy to introduce our Professor Dr. Shahadat Hossain, Line Director, HIS and eHealth, Director MIS, DZHS. And also, we are very fortunate to have Niranjan Dam, Director MIS, Director General of Family Planning. And on the other hand, I have international guest from PATH, Samir Kanwar, and he is a Director Digital Health, and he have experience on implementing digital health in India and other countries as well. And also I have online Anusri. Anusri is a country operator to play the video clip of our one of the keynote speaker, Alan Lebrick, and about DPI in the context of international perspective. So please play the video of Professor Alan Lebrick.
Ladies and gentlemen, distinguished government officials, Assalamu alaikum. It's a privilege to be speaking to you this morning. I only regret that I can't join you in person to participate in this key dialogue on digital public infrastructure. At this year's UN General Assembly, multiple United Nations partners came together at the Digital Health Day, emphasizing the importance of digital public infrastructure as the foundation stone for a successful acceleration towards the completion of our SDG goals. Today, I stand before you to emphasize the pivotal role that digital public infrastructure plays in the establishment of a robust national digital health system. In this digital age, where information and technology converge, harnessing the power of connectivity and data is critical to ensure the health and well-being of our citizens. Bangladesh has been for many years on the forefront of realizing this vision, recognizing that digital is key to a successful future for education, for financial inclusion, for agriculture, civic engagement, and of course, health. Digital public infrastructure is the bedrock upon which the edifice of a robust national digital health system is built. It encompasses a wide range of components, from high-speed internet access and secure data storage to interoperable electronic health records and telehealth services. DPIs must be built on a few key principles. These include, 1, accessibility and equity. Digital public infrastructure must ensure that healthcare services are accessible to all, irrespective of geographic location or socioeconomic status. It has to bring healthcare closer to remote areas and to marginalized communities, promoting equity in access to healthcare services. 2, data-driven decision-making. A solid digital infrastructure must allow for the collection, storage, and analysis of health-related data. This information is invaluable for policymakers and healthcare providers to make informed decisions, allocate resources effectively, and track health trends. First, digital identity systems. Digital identity is the foundation for accessing a wide range of government and healthcare services. It provides individuals with a secure and convenient way to prove their identity, which is essential for activities such as accessing electronic health records, booking appointments, and securely sharing personal health information with healthcare providers. Canonical registries, another example of a mandatory digital public infrastructure. By serving as authoritative sources, canonical registries maintain the integrity and accuracy of essential data that serves everyone. This ensures that healthcare services are provided based on reliable and up-to-date information, reducing the risk of medical errors. And in a national digital health system, various healthcare providers, facilities, and systems must work together seamlessly. Canonical registries provide a foundation for interoperability by offering a common set of identifiers and data formats. Interoperability standards is another space where government has to set the norms. Digital infrastructure in the form of national data and exchange standards ensures that different components of a healthcare system can communicate seamlessly. Interoperable electronic health records, for instance, enable healthcare professionals to access patient information securely and efficiently, leading to better patient care. Robust digital public infrastructure is crucial in protecting sensitive health information from cyber threats. Secure mobile payment systems can be integrated with healthcare services, allowing individuals to pay for medical consultations, prescriptions, and health insurance premiums using their phones. This simplifies financial transaction inclusion and enhances the user-centeredness of care. These examples demonstrate the multifaceted nature of digital public infrastructure in the context of a national digital health system. By investing in and expanding these components, governments can create a foundation that empowers citizens to take control of their health, and it enables healthcare professionals to provide high-quality care efficiently and securely. Dear colleagues and friends in Bangladesh, digital public infrastructure is not a luxury. It is a necessity. It is the cornerstone of a national digital health system, enabling us to provide better, more accessible, and more efficient healthcare to all citizens. As government, it is your responsibility to drive investments in and prioritize the development of this critical base of infrastructure to provide a healthier, more prosperous future for all people. Thank you very much. Dhanyabad.
So thank you, Alan. Even though Alan is not here, just I summarize in 30 seconds what he said. Digital is the key, and we have to create interoperable infrastructure to ensure access and equity and make data-driven decisions for treatment delivery and resource allocations. And I would like to ask one thing. All we know about the MasterCard and Visa, right? We know about the MasterCard and Visa, right? What it do? If you had the card, you can buy anything, any part of the world using your MasterCard and Visa. That actually happened due to digital public infrastructure for financial transactions. At the same way, we can do, if I have a health card, I can use that health card within the country, any places, any facilities, or beyond that in a region or in the world. So I think Alan actually highlighted that the necessity of digital public infrastructure for better health and also ensure equity and universal coverage. Now I would like to request our next keynote speaker, Professor Ahmadul Kabir. He is in India. He is joining in WHO conference. So I'd like to request share his presentations. And on behalf of him, I have to operate his presentations. And Ahmadul Kabir sir, like we are sharing your presentations and you will start your presentations. Please. So sir, you can start your presentations and you can just guide me to go next slide. Sir, you have 7 minutes, sir. Thank you.
Okay. Thank you very much. Ladies and gentlemen, can you hear me, please?
Yes, we can hear you loud and clear.
Okay. Ladies and gentlemen, distinguished panelists, Assalamu alaikum. It is a great privilege for me to speak in front of you in this noon. I really regret that I'm unable to participate in person to this important discussion on DPI. Health is considered as a foundational and constitutional entitlement, and it stands as a priority domain for the government of recognizing the urgency of this issue, it is essential. Digital health is the fact of adopting digital technology to improve health from inception to operation. Digital health includes health informatics, telemedicine, mobile health, e-health, digital health record, uses of emerging and frontier technologies, IoT-based devices, artificial intelligence, genomics, blockchain, virtual reality, and big data analysis. A well-functioning primary healthcare system can cover most of a person's health needs throughout their life. By bridging health systems and service closer to communities, digital health has the potential to become an important driver to help countries to achieve universal health coverage and health for all. Please go to in this slide, as you are seeing that the health has been shown in two ways, and we are showing out the achievement in health sector. So Bangladesh is doing very good in health sectors. You see the lot of achievements are there. Next slide, please. You see the SDG indicator, if we can look at this, the condition of Bangladesh, if we carefully look, there are some bottleneck which is being red marked. And especially the area we need, primary health care, especially the maternal health care and under 5 health care, as well as the HR, which are really bottleneck the indicators, we are behind reaching the SDG target. If we have more, we need to pull it. See the statistics which showing the health delivery system, both public and private sector. It is being increasing the private sector much more than the private public system than the private system. Next slide, please. We have the health infrastructure in primary healthcare, secondary and tertiary healthcare. But our secondary, tertiary healthcare system is well organized. We do have the infrastructure there, but we could not convert it into the digital infrastructure. We need to just convert in the digital infrastructure, but structure is there. We need to make digitalized, though there are many work has already been significantly. So primary healthcare is the underpinning of sustainable development in the secondary and tertiary care. Whenever there is a very good primary healthcare, secondary, tertiary care load will be less. So we need to give more emphasis on the primary healthcare. How we can do it in next 2 or 3 minutes, I will just demonstrate that. Next slide. You see this slide? Here we can show the digital technology and digital inclusions. Through the digital inclusions, we can just develop the share health records, and digital tools is very important. Next slide. Can you go to the next slide? Yes. So you see this digital health includes the availability, accessibility, the healthcare will be much more. And it will be whenever there is accessibility is there, irrespective of the people's financial affordability, in digital accessibility is more important than it will have an efficient outcome. Next slide, please. So this is actually the output which will be given from the digital health input. We can have a use output on the digital health system whenever we can have a digital input from account to the health information to the mark, where we can have enormous output when we can just convert all these things. Next slide, please. Can you go to the next slide? Yes. This is the you can switch to the next slide.
Is he disconnected? Is he disconnected? Okay, just then we can go to the slide. He came back? No? Okay, no, just 1 second. I'm operating. Okay. I think like he's talking about like maybe just on. I just give some glimpse on the slides about the community clinic will be smart community clinic to support the DPI, and GP center for at the union level, digitally managed to support the DPI again, and having the health account for every citizen and having the data to support health and other collaborative platforms for other people. And then it is like an infrastructure from household to community clinic to USC to Puzhala Health Complex to district hospitals. And the most important things is I think he mentioning about the referrals from household to tertiary care hospitals, ensuring that through digital interventions, which is the biggest challenge in Bangladesh. And similarly, there is a general practitioner model for urban clinics, like ensure preventive, promotive, and primary health care, and referral for secondary and tertiary cares. And also like preventive and primary health care through digital technology for workplaces. You know that workplace health is also important for increasing the productivity, and also ensures our drug stores. We know that our drug store is the one of the point where we buy medicine, whatever we want to buy without prescription, even antibiotics. So that should be controlled using AI and DPI. And then in future, there will be opportunity to having a AI-based prescription audit system to ensure like correctness and reducing the error. And also like how can we use artificial intelligence to scribing to ensure when doctor and patient are having conversation and counseling, then we can capture speech to text and generate to a medical record which is comprehensive. We know about the Augmedix is doing for America, we have to do for Bangladesh. And next is how can AI and DPI can help to develop second opinion system for digital infrastructure and service delivery. And I think I just read on behalf of him. And he is proposing to establish a National Health Authority or National Health Security Office. Under them, there will be a general practitioner model for preventive promotive care in rural and urban areas. And there should be strengthening from public and private facilities for better service and accountability. And introduction of universal health protection scheme. And that already in India established Ayushman Bharat Digital Health Mission and for secondary and tertiary care. That will reduce out-of-pocket expenses significantly. And I request to play the video. Here is a video. Just play the video and then we can finish his presentation on behalf of Professor Ahmad Al-Kabir. Can you play the presentation? You cannot play the video? Video is not there. Okay, anyway. So like in there, he put 6 points here: efficient, accessible, inclusive, affordable, timeless, cyber healthcare service delivery. I think that's the fundamentals of DPI. And we are sorry that for the interruptions. And we Sir is there? Can you play the video? Okay. So can
Thank
you?
Thank you, Dr. Mahmood.
Ahmad Al-Kabir sir, on behalf of you, I just utilize the time to go through your slide, and I would like to listen final remark from you.
No, thank you very much, because I'm in another meeting in WHS. Meeting is going on. I had to come out from the meeting, and sitting in the field, you can see all the people taking lunch here. So a little bit of noisy environment here. So thank you very much for really appreciate your endeavor to carry on this slide presentation. I hope the participant could understand what I actually mean. Basically, digital health system means that there should be digital health account. Everybody, and not only that, from beginning to there, the contact with the GP, that GP model we have shown, and from the GP model reference system should be there as well, and shared health records should be there, and all the providers should have the health records so that it is very much accessible. We do have the infrastructure. We need to convert the digital health infrastructure. One infrastructure is there, but it cannot go for the accessibility. We need the digital conversion of the digital health infrastructure at all levels so that the people can have a very good access to the healthcare systems. That's it. And this is actually what we need to establish the digital health infrastructure. And at the same time, we need the financial affordability. What we wanted to say is that we establish a national health authority who can take over this. And the GP model and smart community clinic model, what we have shown is very important is that somebody should, it is impossible to establish overnight. So we must go through this model through the National Health Authority, so through the strategic practice and others, the gap should be filled up in the urban and community level. Thank you very much for giving me the opportunity, and special thanks to Dr. Mamun for presenting on behalf of me. There were some internet connection problems as well. I'm not sure whether you could get me or not. Thank you.
Thank you, sir. I think your last summary was very enlightful and we got everything. I think from the first presenter, we talk about that why we need DPI. And the second keynote speaker, we clearly got the idea. We really need to establish the digital public infrastructure and utilize the technology's benefit to actually create equitable, accessible healthcare services in urban, rural areas. And he actually tried to mention about that, how can we create accessibility through the general practitioner model for union level and the ward level, and how can we establish referral systems, and also how can we have a universal health protections, and all of these things can only happen if we have an accountable systems. For that, we must have digital health infrastructure. That is, in short, we can get digital public infrastructure. And thank you so much. As we have a limited time, I would like to go for panel discussion. At first, I would like to go to Samir. Samir, you have the microphone. And you are working for the path, and you worked in India and many places. And I would like to get your experience, how you see the transformation of DPI in India and other countries, and how that experience can brought to Bangladesh for our transformation, I could say not a long, in a shorter term. Thank you.
Thanks, Dr. Mamun. Good afternoon, everyone. Pardon me, I've got a bad throat, so probably I'll be a bit low on the volume. I'll divide this into two. A is we've been talking about DPI since morning, and I think we need to attach a suffix to it as DPI for health, right? Because there is a nuance there when we look at health. It is more complex than probably the overall DPIs. And second is I'll just delve into what is happening at the global level when we look at DPIs, and specifically for DPI for health. Right. Now, when we look at the health sector, of course, we've been talking about, having a universal ID since morning. We talked about the payment gateway, and we've talked about the interoperability of data. But there are a few more building blocks which we need to look at when we look at the, health stack, if I may call it, the digital health stack. Now, these building blocks are, you need to have a universal, unique registry for your health workforce, right? You need to have a universal health facility registry, which accounts for all your health facilities, whether it is public or private. Similarly, like I mentioned, for the workforce, so for us, 3 workforces are extremely important. We are looking at doctors, we are looking at nurses, and we are looking at paramedics. When we look at facilities, of course, we are looking at the larger hospitals, but we are also looking at the last clinic, which is a single room clinic, right? Very essential when we look at the primary healthcare piece, which the professor was talking about, and Dr. Mamoon also mentioned, right? You have to look at the laboratories, you have to look at the pharmacy getting registered, right? So how do you get these this entire ecosystem using universal IDs across, right? That's one piece which we need to crack. Apart from, DPI, we've only talked about the national ID for the citizen, right? We haven't talked about these IDs. So you need to look at them as DPIs for health. The second important piece is, how do you make these technologies interoperable, all right? So you would be able to push the public sector. You would say, oh, I have made a software which is going to work in all my health facilities. Tertiary and probably secondary would use a specific piece of HMIS. We all understand what an HMIS is, right? It's nothing but a software being used at a health facility. Now, how do you tackle primary healthcare, right? Where is the software for that? Right? So, and where is the software which is standardized? So public sector is one aspect of it. The private sector is the other aspect. Extremely important, right? In LMICs, when we look at Bangladesh, India, Indonesia, right? Because if I take an example of India, 56% dependency of primary healthcare is on the private sector, right? And we can't shy away from it. We've gone through COVID. We understand the dependencies, right? And the government incentivizes engagement, right? The private sector gets money to give you treatment. There are financial schemes which we are coming out, right? Insurance schemes coming out. So therefore, the private sector engagement is extremely important, all right? So how do you look at the standard software? So the government, or let's say the National Health Authority, which the professor talked about, needs to look at coming up with some kind of a tech platform, a sandbox where people can come test their software, right? And define those standards for Bangladesh, right? You need to define your national standard. There are global standards, for example, the FHIR standard, which defines how your MRIs, the SNOMED defines how the MRI looks like, the X-ray formats are defined, your medical record formats are defined as part of the FHIR. All those standards need to be contextualized to Bangladesh. You need to lay out those standards and then have a digital platform where people can come, test their software, get the compliances, to operate this. Then only you will achieve interoperability when you look at it, right? The last aspect, of this ecosystem is once you've got this interoperability, how do you engage the private sector, right? Because private sector is not going to be ready to adopt technology just because the government starts saying it. We are facing this challenge in India as well. So in India, there was a very specific pilot which we did on behalf of the government to see as to how do we engage, ensure that the private sector, single room doctor actually is able to adopt technology, come on board. What's the incentive for him? Why should he do it at all, right? He's not interested. He's saying my business is going on. So you have to create that value for him. Where is that value for him to engage, right? The last piece is, there has to be a consent framework. All these health records are my records, right? I have the authority to be able to share them, right? The facility cannot, one facility cannot share my record with the other facility. He may have it in the digital form. They may be interoperable, but it has to go through me. So there has to be a consent framework where I am authorized to share my record. Is there a consent framework? Sorry.
Just, Samir, you just sum up in just 30 seconds.
Okay, thanks. So I'll just quickly tell you as to what is happening on the global front. Alan was speaking before the session, right, at the start of the session. In terms, there is already a global initiative on digital health which he's leading, right, at the WHO level, which is going to look at digital health globally, look at standards and how do we operationalize them. That is one piece. For DPIs, there are two initiatives which happened as part of the G20 engagement of India. One was a global DPI repository which is being established, right, across the world, so that, countries can come pick, for example, Bangladesh, makes a DPI and is open to share it with other countries. It will be hosted there. It can be picked by any other country. The second is an initiative known as One Future Alliance, which is looking at supporting countries for funding, for technical support, as well as for capacity building for DPI. So these are available platforms which can be used by other countries. Thank you.
Thank you, Samir. I think you said the experience in India and other countries. I just would like to give you an example. In Bangladesh, if someone wants to apply for a credit card, they have to give salary certificate, these and that, all other documents. But if you, in US, if you apply for the credit card, nothing else. because all of your history, all of your financial transaction is there centrally, and you apply an AI will automatically identify that you are eligible for the credit card. If yes, how much your limit will be. If you don't have that, you could get a prepaid credit card. So this is the beauty of interconnected, interoperable digital public infrastructure. I think Samir rightly said that we need to build that so that we can take the advantage of digital public infrastructure. So I would like to request Kamia to about another question on DPI. What are the problems that DPI approach can solve in healthcare that oppose to a pure digitalization approach? Like we call it Digital Bangladesh, now we're going to Smart Bangladesh, and now we're putting in between the DPI, right? How you distinguish these two, I think that could be helpful for our audience. Thank you.
Yeah, I think, first of all, thank you so much for the invitation to come here. And I was really enjoying the comments both by Samir and Alain. I feel like I can leave and, they can handle it because the content is now so, so widely proliferated. It's really good to see that many others are starting, we're recognizing the core blocks and there's a broad recognition of what the core blocks are. So I think first to start, we should frame this not from a digital perspective, but from a people perspective, right? The core is to say, what do people need, in terms of their health services? And we should not, of course, build technology for the sake of it, right? Of course, digital sounds savvy and it's the new thing and everyone is talking about, but really focusing on how do you get that last slide that Professor Abir had presented of accessible, affordable, inclusive care. I think the baseline that we start this from is to say that solving for healthcare is not new. Many institutions have been trying to do it, as Samirji pointed out. Many private institutions have been trying, community institutions have been trying, public sector has been trying. In many countries, the ratio is skewed one way or the other. In some countries, heavily public sector provided all aspects of healthcare. Like if you look at Canada, everything in healthcare is provided by the government. In many other contexts, you have a heavy private sort of influence where many small private entities or shops, your pharmacy, if you look at an example, country like Sri Lanka, the local pharmacy becomes the doctor, right? Because you go there and you ask them for advice and they tell you.
Same for Bangladesh.
Exactly, same for Bangladesh, right? So there's a very vibrant combination of private and public institutions. Now the question actually to ask is, what is stopping the existing public and private institutions from solving access to care? What is actually holding them back? And that minimal framing of what can catalyze others' ability to solve, whether it's other aspects of government, other branches of government, or other pharmacies and labs, or public hospitals, private hospitals, or care workers, community care workers at a local area. What is preventing low cost of service for them to offer for them? What is preventing high quality? And can we unlock it at scale? That's core of what we're trying to answer with the DPI approach, right? To say we'll only provide what is required for them to solve better. Now, I think the characterization then of what are the blocks that are useful have been really well summarized by both Samirji as well as Alain and Abir. I think we're framing, first of all, to say, there is a core data requirement, but again, the devil is in the detail. Now, what data are you going to put in the facility registry? Are you going to try to put 2,000 fields for every facility and try to scale that across your whole 200 million country? Good luck, right? So I think with many of these blocks, now the question is, in the facility registry, in the patient registry, let's say, or in a professionals registry, in the data sharing mechanism, how do you design and architect it in a way that it will inevitably scale to 200 million? The question is not whether or not these are good ideas. Everyone is telling you this is a good idea. Now it's about the design calibration, and I think at that point, it will become heavily country contextual to say, actually, nobody will do business with another facility in this country unless they know know the address and the geolocation. Maybe that's a field that you add in the facility registry. So I think the way that we're framing now has become very evolved. I'm really glad to see this conversation evolve. I think even 4 or 5 years ago, there was a confusion between all of digital health systems and digital public infrastructure. But I'm glad we are asking this question of, okay, maybe the state doesn't have to build every software required for health. We don't have to build biomedical waste. We don't have to build, supply chain management. All we have to do is define those standard interoperable protocols and the mechanisms for entities to interact with each other. And that will help others to solve. Yeah.
Thank you. I think you really mentioned the most important things, which is called human-centered design. Whatever we design, people should be center of it. So I just would like to say that one thing that happened, I think last year, Bangladesh celebrated almost 100% electrification in all the households in the country. So this is a milestone we achieved in the energy sector, and that actually driving our growth. Similarly, maybe down the line in next 5 years, after 5 years, we could celebrate that every citizen of this country have a digital health account and they have access to affordable quality health care in their community or beyond that through digital, like implementation of digital public infrastructure. And that will bring the real benefit of, in Bangladesh, called Sonar Bangla, right? So I would like to now go to the Anusri. Anusri, can you hear me?
Yes, I can hear you.
Thank you. I have a most critical question to you. Don't be afraid. It's a very easy. So once a country has crafted its digital public infrastructure blueprint, and how do you solve for adoption among all stakeholders? Because we know in the healthcare, we have healthcare managers, doctors, providers, paramedics, nurse, midwives, and other allied healthcare forces. How the adaptation can happen? Why should private player should be integrated in this adaptation to make the integration as a whole? I think this is the biggest challenge many countries faced for digital adaptation. I'd like to hear from you. Please, over to you.
Hello, can everyone hear me?
Yes, yes.
Hear me? Good afternoon, respected panelists and moderators, sir. So first of all, I would like to congratulate all the teams for organizing this splendid conference, and thanks for giving me the opportunity to be a part of it. And as you said, this is the crucial question. This is the billion-dollar question. How do you solve for adoption? And this is something that we're trying to do and trying to properly solve for in India as well. So in one word, if I were to summarize this question, it would be, what is the value proposition that each stakeholder has if they are adopting this particular blueprint or particular DPI framework? So that's where I'll start. Now I would like to expand on it. Let's list the major stakeholders. Could be healthcare facilities and healthcare professionals, and then there are actual end users or patients, and then there is government on one side, and then you have payers or like insurers who are actually paying for people who are getting the care. Now, if you come to each stakeholders, the only sustainable way to drive sustained adoption, not via like simple quick hacks that would just increase your numbers and then people would drop. That's not what I'm talking about. But the only sustained way to increase adoption is to create a long-lasting value proposition for each of the stakeholders. So let's start with the first stakeholder, who are healthcare facilities. Now, we would need to look at what their primary pain points are. So as a healthcare facility, I want to be paid on time, right? I want more patients to come to me, and I also want my money to be dispersed to my account on time. So maybe healthcare claims is one idea or one use case that I really want to be solved for in this entire healthcare ecosystem. So if a blueprint actually solves that problem for me, decreases the turnaround time for the claims, and make sure that more and more people are covered by insurance so that I'm assured of the amount that I'm getting, and also simplifies all the administrative, all that parts of the equation, I will be more and more encouraged to adopt that framework as opposed to just a government enforcing or like forcing me to adopt it. Now let's take a different example for like the end users or patients. So as a patient, what do I want? I want to have all my data with me. I want to see where all have I been and what is my longitudinal health record looking like, so that I can go to a different doctor and show it to them and get the right care that I need. I also, if I'm going to say like a public facility which is very crowded, I really don't want to waste a lot of time standing in queues and like wasting the whole day. I want to get care when I need it, and that too good quality care. So any use cases or any blocks that would enable me to do just this, all these listed needs, I would be more tempted to adopt it. So like personal health records that is easily shareable to my doctors, my any other wellness apps or healthcare startups that I'll be using, etc. So that gives me an incentive to actually adopt this or like come into the whole DPI blueprint of healthcare. Also, here is it's worth mentioning in
Anusri, sorry to interrupt you. Just if you can summarize in 30 seconds, because we are very much in tight of the time. Sorry for that.
Of course. Of course. So I would just quickly go to like the other two stakeholders as well. One is like government and the other is payers or insurers. So insurers would want their claims to be like processed quickly. They don't want to go through the whole processes of like manual adjudication, which is slowing down their entire innovation cycle and also preventing them to like from making new insurance products as well. So any block or any use case that supports them to do that would be something that drives adoption. And finally, from the government side, government, what I believe needs to do is there are some things like putting out maybe white labeled apps or sample software solutions that is easier for smaller players to procure and then come into the system. That's one method the government can use. Second is providing incentives based on like the number of health accounts created or number of data transfers that happened is also another method. But to conclude, to summarize, all this depends on what value proposition is a stakeholder getting from coming into this ecosystem. And that's what we should focus all our energy on, rather than just trying to force fit a solution to a particular stakeholder when they don't really see the value in that.
Thank you.
I would just want
Thank you, Anusri. Thank you. I think, Anusri, you rightly mentioned about the incentive. Incentive doesn't mean that money. It's about the happiness that when they using it, they should be motivated to use it, and that is important. And with that, I would like to share some good news, some hopes. In Bangladesh, we already adopted digital health strategy, and this is one of the biggest milestone that Bangladesh achieved, that digital strategy. And now, with the leadership of Ministry of Health, DGHS, and DGFP, they are now working on creating digital health blueprint. And these are the foundation stone to establishing as a functional DPI for improving our healthcare service delivery, accountability, and access to care. So as we have a very limited time, and now I have the opportunity to have the two leaders who are driving the whole healthcare service in like Bangladesh, both in urban and rural areas, in respective of all the ESP service, secondary tertiary care to family planning, and so on. So I would like to request now one of the distinguished guests from Niranjan Dham, and he is a director of MIS, and he will share about their initiatives, because DGFP have a huge MIS system, and that actually capturing huge data, and they have a service delivery at the grassroots level and in urban areas, and they ensures family planning commodities and service delivery. So I would like to request about how they are reacting on the perspective of smart Bangladesh, how they will transform that digital Bangladesh concept and also health facilities to smart Bangladesh in the perspective of DPI. Sir, over to you.
Good afternoon. Actually, I am from DG Family Planning. DG Family Planning actually committed to deliver the family planning services and other maternal and child services to the people. We are committed. If we want to deliver our services to the people, we need three tiers actually. We have human resource and logistics support, and other was is the facility readiness, I think so. So in terms of human resource support, we have already a digital system of HRIS, Human Resource Information System, and actually 52,000 of our service providers are listed in that HRIS system, and we can monitor all the service providers, where they posted, how many post vacant actually we have on our fingertip actually HRIS system. And another system for the logistics, we have a system actually that is SCIMP, Supply Chain Management Information System. It's a strong system actually. We have 25,000 actually in our field workers, and they ensure actually the family planning service and maternal child health services. How much logistics they have actually in their hand, and what's the need for future 2 months or 3 months, what we have to need, and for the long-term planning for 2 years or 3 years, how much logistics we have to procure. Everything we can actually control by this HCMS system, and it is a good system. I think in this system, all types of logistics actually. The family planning services, it's a regular process. We have to deliver the logistics, that is oral pill or logistics. We maintain the supply system actually. It's mandatory for after 2 months or 3 months, we have to supply the medicines and the other family planning logistics to the clients. So we have this system. And another system actually, when the client come to us, and we have the two types of system. One is domiciliary system. Our FWAs, they go home visit for the pregnant women and the ELCOs, eligible couples, to collect the data, who are the pregnant, who need the family planning services, who are our clients actually, who are taking the oral pill, condom, and other family planning systems. And another system is the facility system. When a pregnant woman is registered in the community level, the data already interoperable to the facility of our MCWC and FWC, and the pregnant woman, when she come to the facility, automatically the data is interoperable, and she can identify our FWV who delivered the pregnant woman. She can identify the pregnant woman who already registered in the community system. And in this system, we actually in 44 districts, we have the electronic registration system of the pregnant women of ELCOs. And other 20 districts, actually, there is the analog system. There is also domiciliary services, and FW take the data in analog system. But we are trying to go for all over the country, roll out the e-registration of all pregnant women, all ELCOs actually. And I think if we can do a universal health ID or universal ID for any personality, and then it can be interoperable with the health system, private system, and the other system actually. Otherwise, without any universal ID, we can't interoperable this data to other organizations. So I I hope that we can, near fortune, we can achieve this dream. I think there will be the universal health ID, and it will be interoperable. And we can take data from not only from the service providers, it's maybe from the client oriented also. A client may be self-registration in this system, and from the service provider, they also register. And I think if two systems is actually working, then we can get the whole data from the community level, and it will help us to data-driven decision to how can I actually serve the people. I think so.
Thank you so much. I think very nicely highlighted that what system they are using, how interoperability can be achieved in the future, and how can we ensure digital identity, that is universal health card for all, and data-driven decisions. I think now the most important thing is Director MIS, DGHS, and I think the scope of the Director MIS is a huge. They actually starts from health service delivery from community clinic to super specialty hospitals. So we know our problems, we know our opportunities. I would like to request sir and highlight that how we can take the advantage of DPI and how we take the opportunity to achieve our establishment of DPI and universal health coverage under his leadership in the Ministry of Health and DGHS and interoperability with other stakeholders. Sir, over to you.
Thank you, Professor Mamun, for nice introducing me. Honorable speakers who speak especially in the start of this session, and also the learned audience and panelists. I think that Bangladesh has made significant improvement in health sector, especially to achieve Millennium Development Goal, MDG, and also I think that almost in right track in achieving universal health coverage and also SDG. But our Honorable Prime Minister declared Digital Bangladesh in 2008, and we already declared for Smart Bangladesh. I think that without smart health system, Smart Bangladesh is very difficult to achieve. We have in our system, especially now, we have a facility center system now. But we have to convert it into the patient-centered system. And for access and inclusiveness of the patients in our system, I think that there is a process, but I think the digital process will enhance this access and inclusiveness of the patients. And the continuum of care. Now the care is the patients come to the facilities and they have the services, but that is not continuum. They go another facilities, they got services or another doctor or like that. So if they, in digital process, we give them the continuum of services for them, for the patients. For this DPI, to develop DPI in Bangladesh, we have already said that we already have a national digital health strategy already approved by the government. And in line of that strategy, we already in the process within 3 months to develop a digital health architecture blueprint. And we have also developed some logistic and policy something regarding especially standard and safety, security, and like that. We have to inline on that in that process. For DPI, digital identification of the people is mandatory for interoperability and other issues. For that, we already take the initiatives to have a unique ID of every citizen of Bangladesh. In synchronized with NID and our birth registration number, we already get the initiatives, and we are piloting within few weeks. We piloting in 8, along with private and public, 8 facilities. And this unique health ID we create for these after creation this health ID to shareable these data within a framework, shareable health record. We try to build up that platform also. And for that platform, standard and other things, we already work on it. I think that in future. We have already facility registry, but we have to standardize it to interoperable with share health record. We have already provider registry. That would be also updated and to shareable with other things. And we, in our system, especially in Bangladesh, there is especially digital infrastructure. There is a big issue in connectivity. There is another issues to build up the digital transformation in facilities, especially in private facilities, also in public facilities, and interoperable process within these private and public facilities. So we work on it, and I think that we already started some automation process. There is connectivity in our all public facilities is there, but we try to up to community level. We try to give it up to community level, but we have up to Upazila level now. In future, we try to give it in all the private facilities also. That is also big challenge for us. So to digital infrastructure, especially in the form of like data center, connectivity, and then with the interoperable software, with a standardized system to develop a health information exchange system with a unique identification of every citizen of Bangladesh. We have a big plan. We have a plan to give a unique ID within up to June, 20 lakh people. Then within next 4 or 5 years, we give to 6 to 7 crore people to give their unique health ID. We develop a personal health record for them, which that record would be shareable with the consent of the people. So there is also issues of consent and other things to develop this system. So we work on it. I think that from sharing this session with other countries, especially India, and with global speak Lebrick, Professor Lebrick also, many of our developing partners and also other ministries, A2I and global respondent also enlighten us. If we enlighten from the global perspective and also from our context, if you have a good plan, blueprint, I think that we develop this system in future under our leadership of our ministry and our DGHS, also with the leadership of our highest Honorable Prime Minister. So with these few words, I again thanks to give me the opportunity to say something here. And I think that we talk much, but there is no interaction within the audience and me. So I'm sorry for that. Thank you.
Thank you. I think Sir should deserve another clap. Okay, I think we are very tight in time. Just I can take 2 questions from the audience. So I think when you ask the questions,
this session importance is audience connection.
Okay, no.
So audience should have.
Okay, you will ask 2 questions. Please don't give very much descriptions. You just ask directly 2 questions so that we can answer the question, because 2 questions from answer and taking the question is 2 minutes. So now you can think about it. So I can take the assistance to take the questions. So I think you can ask the questions.
একটু যদি বলি একটু মানে আমাদের লাঞ্চের পরেও একটা সেশন যেহেতু আছে আমাদের, যদি আপনারা অ্যালাউ করেন আমরা লাঞ্চ করে এসে ওই সেশনটা সহ কোশ্চেন দিতে যাচ্ছে, কারণ যেহেতু আমাদের হেলথের ইন্ডিয়ার একটা এক্সপিরিয়েন্স শেয়ার করার কথা আছে, এটা যেটা আপনাদের মতামতের উপর ভিত্তি করছে, কারণ যেহেতু লাঞ্চ টাইম হয়ে গেছে, 2টা হয়ে গেছে, তো ওই জন্য আমি চাচ্ছি যে কোশ্চেনটা ম্যাক্সিমাম করার জন্য আমি 2টা লিমিট করতে চাচ্ছি না। অনেক
হি ইজ অফারিং লাঞ্চ, don't make the question. I think this is the biggest opportunity.
আমি কোশ্চেনটা হোল্ড করতে বলছি, কোশ্চেনটা হোল্ড করে লাঞ্চ করে আসে এই রুমে বসবো আমরা,
be strong,
বসেই আমরা
yes, he is giving opportunity. Be strong and ask many questions after the lunch. Then it's an opportunity, because after lunch you can feel drowsy and he wants not to be drowsy. Sabbir bhai, you want to ask questions?
No, it's okay. Let's go for the lunch.
Okay.
No, no, then we can take two questions. We can take two questions. Then we'll take 30 minutes break for having lunch and prayer. Then back again. Then our session will continue until 4. Because our two important directors are here. Also our, the external guest is here. So they'll share their country experience. And you'll ask huge question to both the directors, sir.
Yes. And this is a golden opportunity.
Yeah.
So, question ki niche na khan?
Duta.
Two questions. Okay, please, please.
Thank you, everyone.
Another question should be from female. Gender balance. Please, please.
Yes. So thank you, everyone, for all of the insight. I would represent basically the private sector of this part. We basically deploy HMS in different hospitals. So my question to everyone in general would be that obviously this is the way forward. This is what we must do. My question is, how can organizations like ours become part of this, where we are incentivized and we are willing to also put in extra energy and effort, so that, because this entire process will require the help of the private sector also. So do you have plans or any intentions along those lines?
I think
I think that DGFP also, and they are MS director, it is from when we develop something, especially strategy and some legislation policy, we first try to interact with stakeholders from also experience from the global community. For stakeholders, we engage already experts, private, public, and all the stakeholders. We have some workshops, some like that. I think that everybody not possible to include, but representatives from private sectors, especially who are representative in their, there is society is there is some expert person, we try to engage. When we innovate or implement something in our digital system, adopt something in our digital system, we try to have the shared experience with who are engaged with this process. We have a process, and also we have the piloting of that innovations, or in piloting process we also share the experience with them. With this process, if you connect with us, if you have any organizations like that, because every individual not easy to give input, but if you have organizations and validated organizations, we include in our process, in our decision making. Thank you.
Thank you. I think Sir rightly said, and I'm just adding two things. And DZ Health, MIS create the workshop, they organize workshop to call private sectors to share their experience. And there is a WHO Atlas. You can register there and share what is your expertise and softwares and so on, so that it will give the foundation to participate. One more questions before we go for lunch break. Female, any female here, please. So please introduce yourself and ask questions.
Good afternoon, everyone. I'm Professor Sharmin Parveen from Bangladesh University of Health Sciences, Dean of Faculty of Allied Health Sciences and Head Department of Health Informatics. So my question is, as he raised the question, the role of the private sectors. So my question is the role of academic and research bodies. I think they have a tremendous opportunity to contribute in this whole ecosystem, because a lot of contextualization and a lot of research is required to establish or to make the plan successful. So
I think very good questions. I just adding with the questions that I always call it, that if we want to achieve a smart Bangladesh, government need to create the infrastructure. Industry and academia need to use that infrastructure and work together, solve our problems and develop solutions for our people. I think the question can be answered by our Director MIS DZFP, so that it will create the opportunity for industry academia collaboration.
I think we have already a organization, NIPORT. They are actually working about the research and other facilities actually. I think we pull the data from the community level, facility level, and other issues. And if you want to use the data actually for research purpose or anything more, I think it may be interoperable with you also. And NIPORT, the national organization of the health and family planning regards data management and research works. They maintain the research works and give the decision actually, data-driven decision to implement in the field level. I think NIPORT, DGHS, DGFP, and other the universities who are trying to work or research on these issues. I think it may be it is possible actually. I think we can share our data with the universities and other researchers. I think so.
I just adding one thing. Our Honorable Prime Minister, highly emphasizing on medical research. I think nowadays, like in the medical community, everyone is started to focus on research, and you all will be happy to know that last 2 financial years, Honorable Prime Minister allocated 100 crore taka every year for medical research. That's the, actually I could say, way forward that shown by our Honorable Prime Minister, that how medical research can transform not only DPI, also achieving universal health coverage, and can show our capacity to rest of the world that how a developing world can utilize the research, problem-solving approach, and developing low-cost solutions in the developing world and as well as other countries. Like as a moderator, my job is to summarize the things, and time is also limited. So it was a very much enlightening session. I see all the faces who are very much enthusiastic and excited on digital health, digital public health infrastructure, AI, and so on. And we are very fortunate. We have 2 distinguished speakers from WHO and DGHS. And I would like to say that why our like ADG is in India, you all will be happy to know this is a pride moment for Bangladesh. Our Honorable Prime Minister's daughters and one of the like advisor to mental health in the WHO, Saima Wajid, she is actually candidate for WHO Regional Director. And this is a huge proud moment for Bangladesh. And we pray for her success and winning the election on the November 1 and as a regional director of WHO, and which will be the biggest milestone for Bangladesh, not only DPI, about the transforming the health sector and create Bangladesh as an example for the rest of the world. So this is one thing we are doing here, and we can pray and show our support on that. And I also very privileged to have 2 international speakers, like Samir and Kamia, and also Anusri in the online. And also we have 2 leaders who runs the show of health service delivery, Director MIS DGHS and Director MIS DGFP. They shared their vision, their execution plan, and how they will transform the DPI or implement the DPI for implementing accessible, equitable, interoperable private-public healthcare systems, and which will lead to build our smart Bangladesh with a healthy nation. Because we are a smart Bangladesh. If we are not healthy, then we will not enjoy the benefit of smart Bangladesh. So therefore, we always work for it and hope for the best, and together we will achieve to build healthy Bangladesh. Thank you so much for joining, and it's my privilege to host